All right, welcome everyone. Thank you for joining us today. My name's Leslie Kirby, and I'm the chair of the Community Relations Committee of the Jewish Federation and Jewish Foundation of Nashville and Middle Tennessee. We're happy to have with us today Brian Haile, who's the CEO of Neighborhood Health, and he's going to be talking with us today about an update on our local COVID response. Welcome, Brian. Thank you for joining us. Can you start off just by telling us a little bit about yourself and how you came to have this position? You're on mute, Brian.
I'm the CEO at Neighborhood Health, and one of the things that I've been doing for a long time, actually for about the last 22 years, has been working in and around public benefits eligibility and really making sure that individuals who may lack means do not lack enrollment in the public benefits to which they're entitled. So I did a lot of work in the District of Columbia for the Welfare Office, the Medicaid program there, before moving to Tennessee, working in TennCare, and with the expansion of different programs under the Affordable Care Act, trying to get folks enrolled in that. I moved to Neighborhood Health to take on some of the big challenges that we face, because even when you expand access to coverage, you don't necessarily, we shouldn't assume that people automatically get access to care. And in fact, what we've seen more recently is a real erosion in access to care, even at this, and it's sort of a paradox, because as insurance has become more accessible, the actual ability of individuals to get care they need might have shrunk. And we'll talk a little bit about that as we go through the presentation today. Is it all right just to go ahead and share the screen?
Yes, definitely.
Wonderful. Well, what I'd like to do is just give everybody a little bit of a taste of Neighborhood Health, and maybe that will influence, I hope, or give you a sense about the context in which we're approaching the COVID-19 pandemic and our role early in the process with respect to testing, and now more recently with respect to vaccination for COVID-19. So in terms of the work that we're doing, just so that you're familiar with our practice, we offer medical, behavioral, and dental services, sort of cradle to grave, if you will, a whole spectrum from prenatal to pediatric to adult medicine and beyond. In terms of who we serve, about 31,000 patients in 2019 from 28 counties. Although our facilities are only in 2, we do attract a good number of people from outlying regions. We serve a lot of individuals who don't traditionally have access to the health system. We are the leading provider, safety net provider of primary care for African Americans and more generally for persons of color. Almost 60% of our patients are uninsured, and you get a sense about how many people that we're serving who are residents of public housing, not to count individuals who are also in subsidized or low-income housing, and individuals who are experiencing homelessness. And as you can imagine, it's a population that struggles with a number of health conditions. Now, what we are is a full scope, real deal medical home. So we pride ourselves on opening at 7, closing at 8, and providing Saturday access. We even have telehealth services, and we've got a co-located dispensary and pharmacy. So our goal is to make sure our patients lack for nothing when it comes to access. Now, that access is tough because the geography of Nashville has shifted pretty dramatically. And what you have in front of you, this is an old map, but it's still pretty representative of what folks see, which are the traditional poverty corridors in Nashville. The poverty corridor that kind of starts at the upper end of Gallatin Road, comes down, and then you see North Nashville and Bordeaux, and then sort of out Murfreesboro Pike or Nolensville Road. Those are the areas in Nashville where the poor are really concentrated. And so those are traditionally places where we've located our public or our community clinics. And in fact, we have 11 clinics all up and down those poverty corridors, and even one out in Lebanon. The problem, though, is that what we're serving really isn't the poor, it's the uninsured. And when we look at the uninsured map of Nashville, it's really an east versus west kind of context. And so what we're doing and what we're called to do is really expanding access in neighborhoods that cover sort of the larger part of North, East, and South Nashville collectively. Now, the evolution of the underserved has also changed. We're used to serving public housing residents. We opened our first clinic in the Casey neighborhood in 1976. And we've been serving patients experiencing homelessness for a long time. But what's shifted in the past 10 years are we're seeing many more people with high deductible health plans, people whose insurance is pretty fluid or changing because they change jobs, or more recently they've lost jobs, and a lot of self-employed individuals who are working, who started a business or who are doing gig work, or may work for a small business that doesn't offer coverage. That's shown up. The other part is that, as people get married or divorced, their coverage status will shift with their marital status. The other part about, not only has the population within Nashville and their insurance status changed, we have new Nashvillians. So we have lots of new residents arriving at the periphery of the county, and a good proportion of foreign-born Nashvillians. At the same time, we're also seeing more and more people with opioid use disorder. Just this year, I think, or excuse me, in the past year, we saw a 74% increase in opioid-related overdoses. So the needs of our population are certainly shifting. Now, at Neighborhood Health, we take the community health part of a community health center really seriously. And even before the COVID-19 epidemic or pandemic, we were responding to a number of different outbreaks. The hepatitis A outbreak that was really started in about May of 2018. We were a leading vaccination provider for injection drug users and folks experiencing homelessness and others. We're providing hepatitis C treatment, trying to eliminate that disease. And the same with HIV, we're providing treatment there, but also pre-exposure prophylaxis to eliminate or to help reduce the spread of HIV. And we do lots of screening for sexually transmitted infections. Doing tons of work around childhood vaccination, although statewide vaccinations are down about 70%. And so one of the things that we're going to redouble our efforts on in this coming year is to make sure that while we're vaccinating against COVID, we're not losing sight of the fact that measles is a huge risk. And again, as I mentioned, working to avert overdoses by doing lots of distribution of Narcan and other opioid reversal agents. The last part, and I don't want to treat pregnancy as a pandemic, it's not, but we also work to make sure that folks who choose to or trying to avert pregnancy have that option. So we do lots of work around long-acting reversible contraceptives. So, gosh, that's a lot of work that we're doing, but we're doing it in a context that's shifted. And this context is going to be really important to understand as we think about what's going on with COVID-19. In 2017, of course, then Mayor Berry, 3 mayors ago, if you'll believe it, announced that she would close Nashville General. And that's all fine and good. Nashville General remained open, but about probably 1,500 uninsured patients migrated from Nashville General to Neighborhood Health during that period, either because they thought the hospital was closing or their provider left. And so they had to find a new provider and they came here. So we saw an exodus of patients and just absorbed them and their costs within our structure. At the same time, TennCare cut off hundreds of thousands of individuals. Initially, it was estimated 128,000. That number grew over time. And between April 2016 and April 2019, we saw a reduction in about 1.2 million people from the TennCare rolls, a pretty steady decrease. And so when we think about who was seeking out coverage from us, we had a lot of people that previously had TennCare that suddenly lost TennCare, but their need for care didn't end, and they were continuing to get care at Neighborhood Health, even though we didn't have a payer status for them. Ultimately, over about 220,000 kids faced the loss of health insurance, and that was a huge blow to not only Neighborhood Health, but certainly to these families who had less access to care more generally. Now, that was all prior to the pandemic, and then 2020 was quite the year. I mean, we started with the tornado in which we lost on March 3rd our largest medical and dental clinic at 905 Main Street. We were affected by the social justice protests all through the year, and in fact, we had individuals enter our clinics who were armed, screaming racial epithets, and so we were dealing with the security issues that accompanied that. Not speaking of things that were changing, certainly we had there were a lot of things going on with respect to voting. And you might be surprised, but this really affects our clinic because we had clinics in 2 areas where they had early voting taking place. And so just getting parking for patients during early voting when we had such dramatic turnouts was a real challenge. And let's not forget COVID, which was a huge issue. So what we did in 2020 was pretty impressive. We saw about 26,200 patients by the end of December. And I put year to date because we're still getting the final numbers on that. We saw over 83,000 had 83,000 encounters. The numbers were a little bit lower, but even during a period of a pandemic, we maintained access we were able to do that by providing over 30,000 telehealth visits. In the entire period of 2019, we had 1 telehealth visit. In 2020, we had over 30,000. And we did 1,200 more behavioral health visits in 2020 than we did in 2019. We distributed almost 20,000 diapers during that period and almost about 3,500 food boxes to people who really needed that support and that assistance. What we're also turning to now is making sure that our patients, and really, again, remembering that we're the largest primary care safety net provider in Middle Tennessee, and certainly the largest for persons of color, really trying to reverse what we're seeing in terms of disparities. What the graphs that show up here, really through early January, show how white Tennesseans have really gotten that ramped up with respect to their access to vaccinations. But the rates with respect to individuals who are African American or who are Hispanic have been much, much lower and have grown at a much lower rate. So that remains a key concern for us. But I think it gets back to why are we so focused on the advocacy efforts here? Well, it's our mission. I mean, we're committed to eliminating barriers to care and serving as a healthcare home. And that work really involves advocacy on some level around a lot of these issues with respect to vaccination. It really just is, it's emblematic of what our staff show, and that's in our logo, which is heart. How do we really put our heart and soul into this work to make sure that people do have access to vaccination? I'm going to jump for just a second into vaccination and let's talk through how that's working. So the disparities that I mentioned a moment ago, well, what caused them? Early in the process, necessarily so, the state focused and had to rely on hospitals because at least initially the only vaccine available was from Pfizer. It was delivered in box or in quantities of 1,000 doses per time, and it had really stringent cold storage requirements. And so to be able to accept the number or quantity of doses and provide storage for all those doses really limited it to certain high volume pharmacies and most specifically the hospitals. The problem with that approach was that hospitals, specifically Vanderbilt and St. Thomas in our region, restricted vaccination to their established patients. Well, since those facilities either don't accept TennCare or only accept it on a highly selective basis and provide only the federally required minimums for the uninsured, you've got a population that's going to be disproportionately white and disproportionately wealthy that had access to vaccines to the exclusion of others. The other part about hospitals is that when you think of those facilities, they're located primarily in the western part of Nashville. Well, what do we know about the underserved, uninsured, and the poor? They're disproportionately located in the eastern part of the city. The other part about this is the hospitals only did scheduling through web-based portals. And those web portals really restrict access in the sense that if the libraries are closed and the community center computer labs are closed, and you don't have a computer at home with internet access, how are you going to get an appointment? There was no number to call. The other part that caused a lot of the disparities, frankly, was limited public education from the previous Trump administration. So you had a hospital-centric system that had extremely restricted access to persons of color and more generally to persons who were underserved, and you had little in the way of public education to combat that. Now, to their credit, the Tennessee Department of Health and Commissioner Piercy issued a change in policy on January 5th, requiring hospitals to open up access to all individuals, not restricting it to just their established patients. There was a lot of pushback from the Tennessee Hospital Association, various members. Ballad Healthcare, where I'm from in Upper East Tennessee, refused to continue vaccinating if it couldn't restrict it to its current patients. And so it was a pretty ugly debate, but to Commissioner Piercy's eternal credit, she held firm, and now we're seeing much larger access. One of the things that Commissioner Piercy also did was join 32 other states to put COVID vaccination, specifically the Moderna vaccine that doesn't have the same cold storage requirements, into community health centers like neighborhood health. But that focus on the underserved only tells part of the issue. One of the things that's happened in Washington, D.C., for example, where I used to work, is that my former colleague, George Boyd, who works for Bread for the City clinics, made a comment in the New York Times about what was happening in his Anacostia clinic site. Anacostia is probably almost exclusively an African-American neighborhood in Washington, D.C. It's one of the poorest areas of the city, and it's just across the Anacostia River from Capitol Hill. One of the things that George Boyd noted was that he'd never seen that many white people in Anacostia, much less his clinic waiting room, until such time as his clinic got the vaccine, and they were inundated with residents from Capitol Hill who left their neighborhood and got and signed up for almost all of the appointments at the clinics that were really really focused on the underserved. So just because we put vaccine in community health centers and access points doesn't mean that it will necessarily be available to the underserved. We have to be very intentional about that, which is what we've done at Neighborhood Health. We prioritize several types of patients, specifically residents of public housing who met the age criteria, individuals experiencing homelessness. And in fact, the first shot that we gave, we received vaccine 2 weeks ago on Tuesday. The first shots that we gave were on Wednesday morning. And the very first shot was to a 79-year-old man whose birthday was the day before, and he was experiencing homelessness, who lived in an encampment. We're also doing lots of work to make sure families of immigrant origin who have not had a lot of access to the system also have vaccination. That's a pretty small population in Nashville, not the immigrant population overall, but the immigrant population age 70 and older is actually relatively small, but it's important that we're reaching out to them. We also ourselves at Neighborhood Health have over 1,000 patients who are age 70 plus, and we've been reaching out to them. We've made at least 3 phone calls to each of those patients. We've sent texts, postcards, and emails to sort of get them in and get them vaccinated. And there are other phase 1A1 individuals, people who are in group homes for folks with intellectual disabilities and the like. We've also vaccinated them and some healthcare workers, including home care health aides. That prioritized approach is our way of making sure that the vaccine to which we were with which we were entrusted really makes its way into the arms of the underserved. And I think that that really underscores a key issue for us, which is this is about access. It's about geographic access in the east and southern parts of the city. It's about making sure people don't have to have computers and internet access. So we allow people to sign up by phone, by faxing. They can text us, they can take a picture of something and send it to us, or they can go through our partner organizations to sign up for appointments. We also go the distance to make sure that we provide transportation, or that we work with WeGo and MTA to make sure individuals can get access, can get a ride to their appointment. And by providing Saturday appointments, we also want to make room for adult children who are working to be able to bring their parents on the weekends if that's more convenient to them. But we still face a number of patient questions. People who say, gosh, I feel like I should ask my doctor if this is right for me, or I take lisinopril, metformin, fill in the blank on the medication, is this right for me? The problem with those questions is the answers are, yes, it's right for you. The issue is if you need to talk to your doctor and you're not our patient, it's going to take you a while to get an appointment. You need to get vaccinated now. Your risk is urgent. How do we make that work? And that's really a large public education campaign that it's incumbent on all of us to undertake. And I really can't underscore the urgency of now. What public health epidemiologists in Tennessee are telling us is that the new, more virulent strain of COVID-19 will become dominant in our area in March. And so making sure that that more transmissible variant is not leading to many more infections among those who are at highest risk of death is our most pressing priority. So I really want to come back to this issue of access. It's critical, and getting these patient questions answered and getting patient education really on the forefront of our public health agenda is key. Now at Neighborhood Health, we're doing the hard work to make sure that this is happening, but I want to give credit to all of our community partners, specifically MDHA. I can't say enough great things about our public housing authority here in Nashville, also the Lebanon Housing Authority. We're working with the social workers and navigators at those facilities to make sure that their residents age 70 and older can get vaccinated. We're also doing lots of work with Connexion Americas, the Tennessee Immigration and Refugee Rights Coalition, Catholic Charities, the American Muslim Advisory Council, and others, really to make sure that folks who were sort of left out in the cold from lots of different, throughout this pandemic and who've been disproportionately impacted nonetheless, have prioritized access to vaccine within our clinics. Now, the risks are pretty large, and I want to spend just a second talking through what some of these risks were and how we're getting around them. And really, I'd love your feedback, because on some level, you're going to be, I hope in this webinar, a real thought partner to us to make sure that we're looking at this the right way. We were initially worried that media coverage of the announcement that we got vaccine would lead to, just our call center would be overrun. That had happened to a number of community health centers in other states. Much to the credit of Commissioner Piercy, one of the things that they did was they made an initial announcement on a Tuesday or Wednesday. They rolled out, they waited until Thursday or Friday to release the actual names of the clinics that got vaccine. That meant that it didn't appear in most of the broadcast local news stations until the weekend, giving us more time to increase our call center capacity and set up direct dial numbers so that patients would have access. This was important because you got to remember, we have diabetics that are calling for insulin refills all day long. And so what we couldn't have is to have our call center go down or people not have access to getting refills or appointments, because that could cause any very large amount of morbidity, mortality. And getting to non-patients was critically important to us. And that's, again, the role of our community partners, helping us reach people who were not necessarily our patients, but who were certainly medically underserved, and making sure that those individuals had access. We had a large issue with no-show rates. In a community clinic like ours, it's traditional for us to see a no-show rate of 35 to 38%. When you think about a private medical practice, they're looking at a 5 to 8% no-show rate. Ours is much higher because our patients don't have reliable access to transportation and they have other barriers to getting to a clinic. So how do you manage a no-show rate, especially once you've defrosted vaccine? How do you really make that work? And so it's taken some time for us to have a good process in place to manage a waiting list and make that work. But we've been able to do it such that we've had not one single wasted dose. And that's, we've had some feverish calls to people to get them in to get vaccinated earlier than they expected, but it was just because we had doses. Once we puncture a vial, we only have 6 hours before we have to get the last dose in that vial in arms. One other thing about this is when we started this, we were told to expect 10 doses per vial. But lo and behold, every once in a while, like every 4th or 5th vial, you have an 11 dose. And that unexpected 11 dose, we don't want to waste that either. And so getting that in the arms of patients is critically important. Had a lot of problems with pre and post-vaccination paperwork. We're required legally to provide 10 pages of paperwork, none of which is written at the 6th grade reading level, to all of our patients. That's really hard and overwhelming because we have to provide something called an emergency use authorization document from the FDA. It's about as interesting as it sounds. And we have to provide that because the Moderna vaccine is still technically experimental. But what we're trying to do is put the 1 or 2 pages that are most important in terms of content, print that in color and make that available. That sounds pretty simple. It is kind of simple, but the problem is when you want to print things in bulk and color, a little bit of a time delay there. And so making that work is important. One of the other points, and I think that this is really impressive from West Virginia, you've got Pfizer vaccine and you have Moderna vaccine. Everybody gets the same CDC card. It's just, how do you know which vaccine you've got? Well, if you can read the small print, it'll tell you. One of the things that West Virginia did is I think they used blue cards for Pfizer and green cards for Moderna or something like that. Brilliant. It makes it really, really easy. We're not quite there yet because we're still using white cardstock, but we'll probably move to something like that. And it's easier for us on some level because all of our vaccine is Moderna. But it's just those kinds of low-tech, simple solutions make all the difference. We also had an early requirement that every single vaccine have a 15-minute face-to-face encounter with a physician or a nurse practitioner. You can't do shots in arms and bring things to scale if you have to spend 15 minutes with a licensed provider with each patient. It's taken us a while to sort through the legal issues to get standing orders in place by which we can vaccinate without that face-to-face encounter. but that standing order will be formally promulgated today and will be operating under that as early as next week. We have little things like making sure people stay for 15 minutes. And initially it was proposed to us by some well-meaning federal folks that, gosh, we could have folks download an app on their phone. One of our staff said, no way, we're either going to take their car keys or we're going to put a parking cone in back so they can't back up. And then we'll give their car keys back to them, or we will remove the parking cone in 15 minutes. It's just low-tech solutions to making things work. And I guess the other part about this is really getting to scale while remaining focused on the prioritized populations that we have. And that's where I'm going to ask for your feedback here in just a few minutes. The last part I want to just talk through for a second are messaging to patients. One of the things that's really important is the second dose strong. Getting that second dose is critically important, but there are higher rates of more severe side effects with the second dose. And when I say more severe, I'm talking about 24 hours of feeling cruddy. I'm not talking about more severe anaphylaxis or reactions around allergic shock or allergic reactions in that form. It's just a higher proportion of folks, still a low frequency, but it's a higher number than with the first dose, are going to have soreness. We're going to have some flu-like symptoms. We're going to have to push through that because flu-like symptoms are a lot better than ventilators. So second dose strong becomes really important. Knowing your answer is going to be really, really key, and getting some professional marketing and communications help around this is key. So if you know someone at a local communications firm who really understands how to communicate effectively, can put social media content together for us and put that out there, that would be great. I think we really need to depend on professionals here because we're working with very little sleep and not a lot of time. And so what we need to do is really have professionals parachute in, help us with this and make that work. I'm going to come to our outreach plan in just a moment. So before I turn to our outreach plan and get your feedback on that, let me just pause and ask you what questions or comments you might have about what I've shared thus far.
I think we're a small enough group today that people can unmute and ask questions directly rather than having to put them in the chat. I have a couple just to kick us off though. So you're providing a lot of services and I'm guessing they're not all covered by TennCare. Where does the rest of your funding come from?
It comes from folks like you. And so one of the things that really makes neighborhood health special and important is that we can, as Nashville leans into us, we lean into Nashville. So in this moment where we're focused on making sure the underserved get shots in arms, I am spending money like a drunken sailor. And but one of the things that I had a really, I told our board on Tuesday, January 26th, I said, gosh, we don't vaccine 6 hours ago. We were told it was going to come 4 weeks from now. It came this morning. We thought we were going to get 300 doses. We got 900. We're going to figure this out. I'm going to spend a bunch of money. I hope that's okay. And the board said the most important thing we can do is get shots in arms. We will fundraise later. So one of the things that I would ask is that if you can, please do try to help us out. Our focus right now is not on fundraising. We are not doing development appeals. Everyone who can do anything is being deployed for our vaccination efforts. So our billing staff are helping manage parking lots and serving as greeters. If you can schedule patients, that's great. That's what you're doing. You're not doing your normal job. And as a consequence of that, we're just hoping that people will recognize that and step up. So thank you for asking the question. And I'm hopeful that that some of you or folks that you know will can help us out.
Great. There have been reports in the news that about 20 to 25% of Americans are wary of getting the vaccine. Do you find that the numbers of people you're working with are similar to that, or are there more or less?
Yeah, I think that's probably a low number in terms of those who are wary. When we look at frontline hospital workers, the take-up rate for vaccinations was only about 55%. It's a little bit higher at neighborhood health, probably closer to 65%. But even with healthcare workers, there's who are exposed to, had direct exposure through their work. There's still some reticence about this. There's also some issues around vaccine guilt. Just because I have access to the vaccine, but mama doesn't, is that fair? I think those are real issues. I'm not sure how to resolve them. And I think, unfortunately, we haven't done, this is an area where we're going to need a broad population-based education campaign that's led at the state and federal levels. It's sort of beyond what we can do at a clinic, but I think that the scope of the issue is huge. And so we're going to have to make a real societal issue around this. I do want to pause for a second, though, because I think that there is a really dastardly, cynical ploy by vested interest in the health industry to talk about vaccination hesitancy. And one of the things where, when I hear vaccine hesitancy talked about by leaders of healthcare facilities that kept the poor out of that kept themselves out of vaccinating the poor, and they talk repeatedly about vaccine hesitancy, I think it's a whitewash. We've to push through that and say, you know what? I'm willing to take vaccine hesitancy seriously, but we've got to make sure vaccine access is real. And so let's talk about access now, and we'll talk about hesitancy on a parallel track. But every time a lot of these healthcare leaders are asked about access, they pivot very conveniently, and I think cynically, towards hesitancy. And I want to keep the frame very squarely on access, because what we do know is there are a number of people in communities of color and in underserved communities who do want the vaccine, but don't effectively have access. So let's make sure we're taking care of those folks now, even as we're growing the demand for vaccine across society.
That's an excellent point. There have been reports in the news that Memphis and Nashville are getting lower proportions of the vaccine than other parts of the state. Has that been your experience? I mean, I know you've only recently gotten it, but.
Yeah, so there are a couple of really interesting issues around how vaccine was distributed across the state. I think what we're seeing statewide is it's fair to say that there are higher rates of population vaccine in East Tennessee. And so the question really is why? And I'm from East Tennessee, and I have parents that are over 70 or over 75, as a matter of fact. And so on some level, I was relieved that they had access, but even there, it wasn't easy. Let me explain what I think is going on and why I think it was okay, even as it's changing. What the state made an effort to do is to allocate vaccine in part, I believe, on age distribution. And so the population in East Tennessee is much older than it is in more urban areas like Memphis and Nashville. The other part of the issue is that the state tried to allocate vaccine using something called the Social Vulnerability Index. That's a fine practice. It makes a lot of sense to put vaccine in communities where you have the highest need. The problem with that approach is that just because you put vaccine in hospitals that are located in areas that are adjacent to neighborhoods that have high social vulnerability index numbers, does not mean those hospitals were vaccinating those patients. And so I think the state, to its credit, pivoted very fast when they saw what was happening, made changes to its allocation strategy, forced the hospitals to confront these issues, to expand access, and then started allocating vaccine more broadly to community health centers that were really focused on more underserved populations. So their intent has been pure all along. I think there have been some operational challenges. There have been some hesitant, reluctant, or otherwise partners that were not acting in a way that the state might have hoped. But the state, especially under Commissioner Piercy's leadership, has been highly responsive to these issues around equity. And I'm deeply appreciative of that. I'm not always complimentary of public authorities, but you got to give credit where credit is due, and a lot goes to her and her team.
Great. What about mask mandates? Are you talking to your patients about continuing to wear masks after vaccinations? Are they receptive to that?
Sure, I think they're receptive to mask mandates. One of the things about most of the patients that were vaccinating in Davidson County are pretty sympathetic to mask mandates, but for a perhaps different reason. We refuse to see you if you're not wearing a mask, plain and simple. and it's just for our own staff's protection. So there's a little bit of a filtration effect going on. If you're really resentful of masks, then you're highly unlikely to seek services from us. But I think what we're trying to do is reinforce the importance of the mask mandate consistently. So every time that you want to come to neighborhood health for any reason, you've got to be having a mask on. We'll give you a mask. We've got them in spades, but you've got to be wearing one. And so I think it's a point of emphasis for us. Now, what do they do when they leave? That's a hard question, especially once they have their second dose. What happens then? One of the things that's important, and I think that we can, the line of thinking right now is that what we're going to talk to them about is great. You're vaccinated against COVID. What about the flu? Because you've gotten the flu shot, how effective is the flu shot? So why don't you keep that mask on? Because you still have COPD, and flu and pneumonia are still bad news. And so I think what we're talking about is masks are a good idea because of respiratory illnesses more broadly, not just COVID. And so that point we're going to maintain that as a point of emphasis going forward.
It's interesting. In other countries, masks are nothing new. They often have widespread use of masks in the winter because of general respiratory illnesses, but it hasn't really clicked here. So you mentioned something earlier about armed people coming in with arms during the protests last year. Was that new? Do you have general security issues based on your client population?
So we don't have security issues based on the client population. I think we do serve a number of people.
I meant other people kind of having issues with your client population.
Yeah, absolutely. And so we do have issues where folks, I think there's a couple of things. One, we do try to serve individuals who have been trafficked, who have been pimped, for lack of a better phrase, or who have been victims of domestic violence. And so security is not a new issue for us, and having to deal with those threats are sort of have been ever present. One of the things that shifted, and I see Erwin Vinnick on the phone. Erwin worked with us because we were actively preparing for an INS raid at any point. And so I think and we viewed that as a security threat. That has morphed into more racially driven violence. It last at the latter part of last year. I think now things are relatively calm, but our clinic in Napier that serves the Napier Sudicum neighborhoods was probably on lockdown twice a month because of a shots fired call during the day. And in fact, the most recent lockdown was on Monday morning when Mark Marquette was killed just a couple hundred feet from our clinic. So these are the issues around ambient violence are not new. I think what's different is, and this forced us to have a conversation, an internal conversation. Again, I want to credit Erwin because he's been very helpful to us with this, around how do we think about racial justice in our own organization, and how do we support staff when patients may say very racist things in front of them or to them, and with the intent to hurt. And so that's something that we're taking more seriously because it's happening with increasing frequency, and we're trying to better equip staff. It's going to be a slow process, but that's, at the same time, we have lots of lovely sounding initiatives. I'm going to be frank that the racial justice initiative is a parallel thing, but it will not take priority over shots and arms in the next 2 months. But it is something that is continuing to move forward at our clinics. Right. I will say one other thing about security. Security is expensive. Yes. When we think about this, I had a conversation with the CFO of a Medicaid agency who made a snarky comment to me, and somebody, this is somebody I know and trust, but not from Tennessee, but who made a snarky comment about community health centers really are bloated in terms of their budgets. And I said, really? Well, let me walk you through that. Have you ever tried to rent a parking space in downtown Nashville? Have you ever tried to hire 2 armed security guards to work outside of the clinic? Let me walk you through the overhead that we pay to serve highly dense city neighborhoods where we don't have the parking that Brentwood would afford. You don't have the security issues that Brentwood would afford. You do have lots of social determinants of health issues that require a response, and those responses are expensive. And so that really, I think, contributes to why it's hard to make this work, but and why the donations are so important to us, because to serve the underserved is an expensive endeavor, but it's a necessary one.
Yes, we have, in a very different domain, but a similar issue, that we also have to have security at our local congregations and
Sure.
agencies, and it's staggeringly expensive, but very necessary, unfortunately. Erwin had a question about what everybody else is doing. So it sounds like it's amazing to me that you haven't wasted a single dose of your vaccine, and you're using the waiting list so effectively and all of that. What is the health department doing about vaccine access and trying to make it more equitable? And what are other providers locally doing, if you know?
Yeah. So one of I think there are two major sources of vaccine. The largest source of vaccine for the underserved is and will be Metro Public Health Department. And I believe they stood up their weekend vaccination center at the Music City Center. They can do scale in a way that's really, really impressive. And that how they've been able to make that work is just fantastic. The other part that I really love about Metro, there's two things I really love about Metro Public Health. The first of which is they did offer web-based scheduling, but not exclusively. You could still phone in. That was so important that we allowed that, because it was one of the few counties at the time, at least early in the pandemic, that allowed people to do phone-based scheduling. The second was that Metro Public Health worked hand in glove with WeGo MTA to make sure that car keys did not become a barrier, or access to vehicles or transportation did not become a barrier to getting a vaccination appointment. So my understanding is that Metro Public Health is still doing about 1,200 vaccinations every weekend. That's really, really important, and by far the largest vaccinator of the underserved. We're doing a much lower amount. The level of to reach sort of the underserved folk, people experiencing homelessness, a lot of folks in public housing, it's very labor intensive. And so as a consequence of that, our volumes are not going to be as high. And I think the same is probably true for Siloam Health, which is an immigrant focused nonprofit health clinic. It's located in the Berry Hill. And then more recently on the its second site on Murfreesboro Pike, they're doing lots of outreach to families of immigrant origin to vaccinate those individuals. There are two other health centers in town, Matthew Walker, which got vaccinated this week, I believe 100 doses, and it's vaccinating its patients. And Connect Us Health is vaccinating its patients. Neighborhood Health, because we're the largest primary care provider within the safety net in Middle Tennessee, we got a much larger allocation of vaccine. And we just made a promise that we would serve every public housing resident. It didn't matter if it was located near our clinic or not. We would serve every person experiencing homelessness. We would serve every family of immigrant origin, and we would serve every patient known to us. We were just going to make that happen. And we've not yet exhausted our supply of vaccine. We're working to do that, and then once we do, then we're gonna push out a little bit. We're gonna request more and keep putting shots in arms.
That's great. What are the criteria for people to use your services?
That's a hard question, and so that's an excellent pivot. Thank you very much to the folks that on the call. And what I'm going to put in, I'm going to share my screen, but because it's a little bit difficult, I'm going to point you to a web link in the chat box so that you can play the at-home game if you want to and read. And I have trouble sometimes reading stuff online, but what I've got for you is a very bad outline, and I want to stress this. It was updated as of this morning about what we're doing, and so I'm going to walk you through this because I'd love your feedback about how we improve things. Our outreach to date, or that we're continuing to take referrals from our partner agencies at MDHA, the Public Housing Authority, Lebanon Housing Authority, Open Table Nashville, Room in the Inn, The Mission, all of which serve populations experiencing homelessness. Connecting Americas, Tennessee Immigration and Refugee Rights Coalition, Catholic Charities, American Muslim Advisory Council, and other nonprofits who do essentially do some case management and who can make direct referrals to us. We've also we have called every single patient, and again, I'll have to spell this correctly or use the right. Every patient age 75 times, excuse me, not call them 75 times. Every patient age 75 and older at least 2 or 3 times, are in the process of doing the same for those 70 to 74. We've sent out postcards, we've sent out texts. Later today, we're sending out an email blast to all of our patients. We're sending additional text about and giving them a new dedicated number that we brought online, the 615-953-0050. And what we're trying to do is say, if you've been vaccinated, great, send us one of your friends, send us one of your relatives, because if you're underserved, chances are the referral you make to us is also going to be a person that's underserved. We will share on Monday a call to action with the Interdenominational Ministers Fellowship, really focusing on congregations that are disproportionately comprised of persons of color, saying that we'll vaccinate all congregants age 70 plus. We've also been doing the same work with Catholic Charities and the American Muslim Advisory Council, so that we reach mosques and indeed all communities of faith. We want to work with the Meals on Wheels providers to make their both clients and their volunteers who meet the age threshold of 70 so that they can get vaccinated. We want to share a call to action with Second Harvest, Catholic Charities, United Way, and their family resource centers, and other groups that we can vaccinate their clients and their volunteers age 70 plus. Trying to reach out to the senior centers, although that's a little bit more difficult since so many of them are either closed or operate on severely constricted hours. But with our focus on East, South, and North Nashville. And we're going to work next week with council members in several districts that are in the zip codes that are hardest hit by COVID-19. And I list those for you here: Madison, Inglewood, Dickerson, Pike, and East Nashville, the Casey neighborhood, Bordeaux and North Nashville, Napier, Sudicum, just south of Midtown, and the Antioch neighborhood in South Nashville. So we will post on our website and social media accounts a call to action and just say, look, we'll vaccinate anybody that's age 70 or older, but our real focus is how do we get information to those who might be considered medically underserved. The things that we're keeping in reserve that we have not done are doing a general media press release so that, Channel 5 would put up our new number or something like that, just because what we're entrusted with is vaccine to get in the arms of the underserved. And what we're trying to do is how to make sure, and I say this with love, since my sister lives in Brentwood. My job isn't to vaccinate Brentwood. My job is to vaccinate sort of North, South, and East Nashville. And how do we sort of stay focused on that? And we're continuing work in the parking lot with the NAACP and the Equity Alliance, trying to figure out, they've been great partners to us, but how do we sort of work with them to reach a broader network of individuals? I would welcome your feedback on this, because this is a draft. We're not communications experts. We're reaching out to groups we're reaching out to individuals who are not traditionally our patients, but still who are underserved. And I would welcome your feedback and suggestions as to what we might add to this list or change about this list that would get shots in the arms of the underserved. So let me open it to you for your ideas.
Anyone have suggestions for Brian about other ways to do outreach?
Brian, are you working with IMF?
Yes, and in part, we sent an initial note to IMF, but we'll follow up on Monday with a more formal call to action so that we can reach those congregations.
And what about, I think there's an organization called 50 Forward that serves older adults. That might be a good resource.
We're going to work with 50 Forward. I think we're going to start our work with 50 Forward with Meals on Wheels and kind of grow from there. And again, the issue is both with 50 Forward and with Hands on Nashville, how do you make sure that it's really focused on underserved folks. And so we thought we'd start with the Meals on Wheels and kind of grow outward. But
Okay.
that great idea, and we'll continue to grow our relationship both with 50 Forward and Hands on Nashville.
Brian, one connection in the Hispanic community is Pastor Rodriguez. Are you? I think they're the largest system of churches in the Hispanic community.
Bobby, could you help connect me with him? I'd
I
love to.
will. I'm just looking up their email now. I will.
Thank you.
Yeah, there's also a large Spanish congregation it's the Methodist Church on Vanderbilt campus. I'll get you the contact for that, but there's a huge, they have a huge population, a specifically Spanish language group that meets there in that church. And I'll get you the contact name for that too.
Thank you.
What about things like grocery stores and neighborhood markets? Can you get the word out that way in the communities that you're targeting?
Sure. I mean, there's no reason why we shouldn't put up flyers, and going a step beyond, maybe even laundromats. And so, sure, absolutely, that's a really good idea.
Especially the Spanish speaking markets, specifically for or any of the immigrant markets in Nolensville. There are a lot of ethnic markets that are specifically serving immigrant populations. That's actually a great place for these flyers.
Brian, I'm thinking, and I'm not offering more on your plate than you already have, but even if these ethnic markets are willing to drop a note into the grocery bags that people take home, they don't read flyers and they won't have a pencil to write information down, but dropping a note in a grocery bag seems to be a way to.
And if that's the kind of thing, we have our own volunteer portal and we do some volunteer work, and that's the sort of thing, if you were able to get some small piece and the markets where we could maybe get volunteers to bring them to the markets to ask them to include them. That's something we could possibly add to our volunteer portal as something that we might be able to get volunteers to be willing to do.
So I can do a couple of things. I can do a lot of things, because if folks will volunteer, then that's awesome. I can get camera ready document, like a PDF of a poster. I could get hard copies of posters printed. I can get you tiny flyers to give to markets. What kind of materials would you like? And do you just want the PDFs so that you can print them, or do you want me to deliver hard copies?
I think we can probably through our budget print, like if we had the electronic version of what you wanted printed, I think that we could find some money in our budget to do the actual printing and then try to get volunteers to bring them around.
It'd be great.
Other suggestions?
Your list is amazingly comprehensive already. It's impressive. I so appreciate how much you're doing.
Well, and so let me ask too. One of the things that I'm not aware of any synagogues or congregations in our service area. And our service area is primarily East Nashville and South Nashville. But am I missing some? Is there some that we should really be reaching out to that I might not have thought to contact?
No, our congregations are pretty concentrated in kind of Central and West Nashville, but we do have an organization that works with kind of people in need in the Jewish community, Jewish Family Services, and Deborah can put you in touch with the director there. She can get information out to that group. There is kind of an unofficial group in East Nashville. It's not a formal congregation, but they meet regularly, and Erwin just noted that. They tend to not be probably in the population that you're going to try to serve, but they would be a great source for volunteers. And so we can, again, kind of put you in touch with them as well.
That'd be awesome. Thank you.
Brian, can we go back to fundraising for a second?
Sure.
You know, we're limited in how much hands-on help we could give you, but we can certainly help raise monies through word of mouth. And maybe that's something. We have a Seder coming up. This would be appropriate to mention at our community Seder, but we all have reaches into the community, and maybe an earmarked explanation of the work you do coupled with call out for support would be happy to engage. Our roundtable for sure would be happy to do that.
Thank you. I think too, some of what we're saying really gets to what we're going to need specifically for folks experiencing homelessness, sleeping bags, tents, and the reason why I'm using those is we're not able to vaccinate people in the mission, and because of the close quarters of the mission, a lot of folks have decided that they just rather sleep in the woods. And what we're trying to do is provide sleeping bags, blankets, and tents to those folks to help keep them safe. And we also provide them cell phones with limited minutes, so if they need to call 911, they can. So that would be, I think, related to that. The things that we always need are tents, sleeping bags, and blankets, and then diabetic socks. So those kinds of things would go a long way. And again, it's just to bridge us until we get to phase 1C. And when we get to we're in phase 1A2 right now. Once we're in phase 1C, we're going to try to vaccinate the entire mission over 3 weekends, but until we're allowed to do that, and that won't be until probably May or June. We're just trying to help people get through right now.
Great. Any final questions for Brian or suggestions for him about outreach?
No, but I would like to pursue that offline with you, Brian, about how we could help raise dollars for the work you're doing.
And I do just want to loop back. Ricky posted earlier that Nashville opened appointments for people 70 and over this morning. And she has an appointment for Sunday. So yay.
Oh, good.
Good for you guys. Thank you so much for joining us today. I really appreciate it. It's been really informative. I didn't know about the work your organization was doing, so I'm really glad to have learned about it. And I do think we can help plug some volunteers into your efforts around outreach. So thank you. And thank you everyone else for logging on to the call. Brian, Erwin says, good work.
Yeah. Thank you,
and-
Brian. And I'll follow up directly for some